as we talk more about this, we talk about evidence-based practice being on the rise. That's a term, we use, and I hope we use it correctly, because people tend to throw stuff around, but evidence-based is exactly what it says it is. We in medicine are excited that science is shedding more light onto our field, and we are confident that that light will illuminate areas of public health as well. For over a decade, the AMA has convened the Physicians Consortium for Performance Improvement, or the PCPI. Now, when I talk about harmonization, it's when I learned that we've already put together about 250 measure sets the PCPI has. And, as you're probably aware, there are measure sets all over the place. Everybody's got them. The NQF, the AQA, all the letter organizations out there. How do you harmonize all of this stuff so that we in the practice field, in the clinical field, don't get killed trying to keep track of all of them? The term harmonization makes perfectly good sense. The PCPI is made up of more than 170 special societies. Member boards, agencies, and other organizations actively participate. And the goal is to design and apply evidence-based solutions to enhance patient safety and care. We have measure sets, many of them relevant to public health, which include asthma, smoking, substance abuse, preventative care, and screening measures. And I will tell you, this is one of the most due diligent processes I have ever seen in my life. The specialty societies so engaged in this, they want to get it right. And they convene these work groups, and these work groups really do amazing work getting this. They are our people. It's physicians on the ground who know how to do this both academically and in the delivery of care model as well. And when it comes to evidence, the AMA shares its knowledge. In addition to the Council on Science and Public Health reports that I spoke about earlier, the AMA produces something called JAMA Evidence, which offers fundamental tools for understanding and applying medical literature for better clinical outcomes, a quick and dirty way to get the information that you need. Now, I will tell you, and you already know this, national health care reform has been a game changer for all of us and will continue to be so for a time. Whether you liked it or not, whether you approve of the Patient Protection and Affordable Care Act, they should never have taken the PP part out of the front end of it. It's the Patient Protection and Affordable Care Act. Whether you like it or you don't like it, it changed the status quo, and the status quo had to change. We could not and cannot afford to continue what we have been doing in years past. And with that comes health information technology. Now, I'm not techno-savvy, but I'm learning how to do it because I realize it is the best way for me to deliver health care. It allows me to do it more efficiently once I learn how to do it. It allows me to make sure that the data is in there that needs to be in there for improvement purposes and quality measurement. And it allows me, in fact, to provide better prevention when my patient comes into the office. So I know when their last TB skin test was. Did they get their flu shot? What's the status of their colonoscopy, et cetera? So it's that kind of tool set that we need to have available to us. The $19 billion stimulus package dedicated for Medicaid and Medicare services and incentives over 5 years to get more of us interested in it, I hope will do just that. There's been a lot of work around it. I mean, there's no question that not every EMR is good for everybody. There have been problems with this thing, and they're not ironed out by a long shot. This isn't going to happen overnight. If the federal government thinks that docs can turn on a dime and have a health information technology system that works, they're nuts. You can quote me on that. When you don't have health information technology that talks to a hospital, a radiology group, a laboratory, the billing center, and doesn't feed information back and forth, what good is it? It's not any good at all. So all these things have got to be interactive, and they've all got to talk to each other in real time with real good, real live information at the point of care. If I have to run out of my office, out of the exam room, run down the hall to check some other piece of equipment, that's not beneficial to the patient. Used correctly and compassionately, as I mentioned earlier, comparative effectiveness research will help us as well. Now, people say, why do you want comparative effectiveness research? That's just another way for the government to tell me what to do. And I say to them in the office, if I had real-time point-of-care information that I could show the patient that would tell them that an aspirin is better than a $500,000 procedure, that would be beneficial. Now, we have a lot of science out there. We have all kinds of studies out there, but we don't have all the evidence-based research that we need for comparative effectiveness. And it's got to be done, and it's got to be done correctly. But this is not going to be a way of controlling my billing. This is not going to be a way of telling me how to practice medicine. It is simply going to give me the information that I need as a doctor to provide the care that my patients deserve. Health insurance companies have been doing this for years in their own indirect way. But we've got to figure out a better way to do it.